But generally what I like to do, you're thinking that this is maintenance, okay, a liter and a half a day. So if you give someone a liter or a liter and a half, you're giving them what they'll lose in a day. So if you give them that in a day, it's not going to get them hydrated again. And so we need to use more than that, which takes a little effort with glycis, unfortunately, but so generally what I have been doing, and I don't claim this is firm scientific basis, but I've generally been doing a 1 or 2 500cc bags under pressure, and then doing 1 to 2 liters more at 100 an hour, and then considering, and then kind of reevaluating it. It depends partly on how susceptible they are to heart failure, how severely dehydrated they are, how how good their heart is, all those kind of things, how big they are. But that's a reasonable place to start. It might involve 2 sites, but it's generally well tolerated. Again, it's not like they're painful sites. It's just there. So, and then you can continue it, and you may need to continue hydrating. That's not necessarily enough to get someone who's severely dehydrated. They may need several liters, but just maybe continue them at 100 an hour or something to start getting them hydrated. And again, you want to reevaluate. If it's not helping them, then don't do it. If you don't, if there does seem to be benefit, then you evaluate how much more you need and continue it. The one we did hydration on 2 days ago and did help, but ended up becoming clear that that wasn't the main problem. And so I talked to family, and they ended up, at first they were thinking that this is the whole problem, but they ended up realizing that yes, hydration had helped several times in the past, but at this point she's getting beyond the point where that's likely to benefit her. And so we're not going to continue that at this point. Again, you can consider giving them a liter a day maintenance. It's not unreasonable. It's done. It's standard in some places for hospices. Okay, so that is non-medications, and now we're into medications. Medications for delirium, to control it, we mostly use for the active symptoms of delirium. Hyper-alertness, the agitation. Oh, it is getting dark. Is it starting to rain? I don't think it's that. It's starting to get a little... Anyway,
I've been talking a long
I know, I have been. Right? So far, I haven't seen any sleep. Do people want to take a quick break?
No, I was just
something?
kidding.
You okay?
It was getting to be nice.
Okay. And I haven't fallen asleep yet, so that's probably a good sign. All right. So, for all the other stuff we may well do for any type of delirium. Hypoactive delirium, you may well hydrate them. It may reverse it, may get them better. You can certainly do all the things to reverse it for any type of delirium. Obviously, how much you do is going to depend on what benefit you think. Medications, we're primarily looking at delirium that's causing distress to the patient, particularly active symptoms of delirium. So hallucinations, delusions, agitation, things like that. And we're primarily using the antidopaminergic medications. And we do need to use some caution in Parkinsonian problems. I've had that drilled into my head. I'm starting to see that it may not be as much of an issue as I was taught, but it's certainly, there are cases where someone will get this and they will more or less freeze. And, and that's obviously not our ideal. The main problem is the motor issues with dopamine. Dopamine is involved in several things, including motor, certain motor control, so they can really freeze up and get severe Parkinson's, essentially. Because you use dopaminergic drugs. You use dopamine, actually, in Parkinson's, and we're using antidopamine. Haldol is generally considered to be the drug of choice. And this is interesting. The effective doses can range anywhere from 0.5 milligram, some will say even 0.25 milligrams, although I've found that to be a waste of time. But up to maybe 10 milligrams. That's a 20-fold range. How the heck do you know where to start? I'm probably lazy and use one just as a good place to start a lot of the time. But if someone is in bad agitated delirium, one approach that I may take, and I haven't used this as much, it's not on the standing orders, but if someone's in a lot of distress, we can certainly do this, which is, we may start at 1 milligram, but if they're severely agitated, we double it. We can go to 2, and then we can go to 4. maybe some people will say that somewhere between 5 and 10 you probably max out any benefit, and so how high you go beyond 4, I don't know. But and then just kind of keep at that dose until you know if you've got effect, you can either schedule that dose or continue at PRN. Sometimes I'll just do a PRN initially, but I may, if it seems like they'll need it, I'll often schedule some, maybe 3 times a day. Key thing though is, okay, they're doing well. They don't have delirium anymore. You don't necessarily need to keep that, especially if you've gotten rid of the problem. They're now eating and drinking because they're not as delirious. You dealt with a UTI. Well, we want to get people on the lowest effective dose of these medications, like almost any other medicine. So if they don't need it, we want to cut it back and see how. So that's anyone who's on, probably any medication. If they're not showing any indication that they need it, we want to try taking it off. Same goes for opiates. If they're not in pain, we want to start getting them off that or decreasing it. Thorazine is another antidopaminergic. Again, I talked about it. It can be useful at night. It is effective, but it's much more sedating. Atypical medications have less problems with Parkinsonian things, less of the extrapyramidal effects, which tend to be motor, as well as akathisia, that issues with restlessness. Probably better in Parkinson's, so we have been using these in Parkinson's with success. There is some data on that as well. So now here's a case. Get your thoughts on this one. Here's a patient, mild dementia, admitted to the inpatient unit with confusion and agitation. We hydrated the patient, adjusted the medications, we put him on Haldol. Great, doing a whole lot better. Quite well. Ended up using a fairly substantial dose. But a couple days, the patient just starts getting more and more doses. Get just very, very restless. Won't stay still. Constantly trying to get out of bed. Moving legs all the time. Just kind of really, really restless. The family wants us to be increasing Haldol. So what is the next step? What do we do here? What's going on? Again, chance for some good bonus points if anyone. No one at the other one got this one. I had said this.
Do we assume that you've already gone through all the other stuff?
We've hydrated, we've adjusted medications. I will even go further. Their tension's actually pretty good. They're not really confused. They may be pretty close to baseline. They do not want to stay still. Anyone? They don't want to stay still. They do not want to stay still. Akathisia. I think I actually need to put in an extra slide so it says. This is akathisia. Akathisia is a wonderful word. Anyway, what it is it is really equivalent to restless leg syndrome, which has to do with a deficiency of dopamine. And basically restless legs, they just feel this thing. They have to be moved. They have to be there. Like you can't keep them still. Some people will call this the walkies. It is not equivalent to delirium, although occasionally it can be difficult to distinguish, and it's not an easy thing. But this is actually from the Haldol. This is a side effect of the antipsychotic medication. And so they are actually restless because they're getting too much Haldol, so you decrease that and they will get better. So you can decrease it significantly. You can also consider changing to an atypical, which may be less problematic. Atypicals are a heck of a lot more expensive. Risperidone not being too bad, but the others being ridiculous. And I will say, on the whole, when I say Haldol is a drug of choice, all the large studies have not shown any benefit of the new ones compared to Haldol. Every single study that's included Haldol and the new ones, they've been more or less identical. Occasionally, like Zyprexa has a higher side effect profile and is more effective. Well, okay. In any case, increasing it is the wrong answer. So keep that in mind. One of the challenges is all the medicines we can use can cause more problems in this kind of scenario. Morphine can cause opiate toxicity. It can cause delirium. Ativan almost certainly will cloud the sensorium more and worsen delirium, even though it may calm them down. Haldol will tend to reduce the symptoms of delirium, but can cause restlessness. And so just being acutely aware of the medications that we're using, very, very powerful medicines that most of the medical world is quite wary of for good reason, and not to treat them lightly. We need to use them. Don't be afraid, just be aware. So, okay, other medications, benzos, commonly used in many places. Again, I do not like them for this. I do not like the Dr. Fell, the reason why I cannot tell. Have you guys heard that before? I do not like the Dr. Fell, the reason why I cannot tell, but this I know and know full well. I do not like the Dr. Fell. Anyway, that's an old quote. My mom would quote at me, and then I work closely with the chief medical officer at Mission, who is Dr. Fell, and so eventually at one point I quoted that. And I was first doctor who'd heard that. Who'd said it to him a long time. But, anyway, I'm sorry.
So you don't like benzodiazepines?
Especially in delirium. They are the one role I do like them for is the issue of dyspnea, shortness of breath in patients already on an opiate. They are helpful for that. Fortunately, we have a patient even right now who may be faced with the issue of she's either delirious or she's out of breath. So we're probably going to err on the side of deliriousness. But these tend to be they will cloud this insulin. This is an interesting one. I don't know the role of these, but if there's something that will increase acetylcholine in the brain, maybe that'll help that. Right now, I've not seen any good data of the use in delirium. I'm thinking that I'd heard initially some more promising stuff, and I haven't seen anything for a while, so I'm thinking that it may not have panned out as much as they'd hoped, but I don't know. I don't know that this would be the time to stop those medications if someone is acutely delirious, though. I'm not sure. I don't know. On the other hand, if they're getting it on these things, then maybe they're not helping us, we're stopping. Delirium Depakote, really not for delirium so much, but for agitated dementia, which can be a little bit difficult. Okay, now we're going to go for a case. We've done all kinds of stuff to this person. We've treated them aggressively. We've hydrated them. We've done medication changes. We've evaluated every possible cause. We cannot figure out how to help this person. We've tried antipsychotic patients. She's awake. She is miserable. Maybe agitated, maybe confused, maybe out of breath, whatever. She's really not taken much at all by mouth, not surprisingly. This is a difficult scenario. Fortunately, this is a very rare scenario. I've faced it a couple times as we've been here. This one lady I talked about, maybe when we may discuss it, we may end up in this situation just because the breathing. But the question is, what can we do now? This is where we don't have a lot of options. We've used all our normal options, so this is where we use sedation.